Okay, today we are going to dive into pulmonary disorders and related emergencies. When we think about stress reduction protocol, we've been taught in clinic that what? Stress reduction protocol, first thing in the morning appointments. However, there is always an alternative. There's always something that goes against the norm. And for that, we want to think about something like gastroesophageal reflux, right? GERD that we want it to be 2 hours after eating. We also want to think about asthmatics. Asthmatics are better in the late morning. And why is that? So, if you think about, let's start by thinking if you're sick, when are you coughing the worst? I know, at least for me, it always seems to be in the middle of the night, right? So, you get sick, your cough starts to get worse in the middle of the night. It really has to do with you want to think about our vagus nerve, which is cranial nerve number 10, and that kind of controls everything in the chest. So when we go to bed at night, the acid from our stomach, when we're laying flat, it starts to creep up. Cranial nerve number 10 comes in and says, let me help you. I don't want this acid to go into your lungs. So what it does is it starts to cause bronchoconstriction. So it starts to constrict that so that the acid does not get into our lungs, which is why a cough or an asthmatic person, their symptoms are worse at night. We want to give them time to wake up in the morning, and we want that vagus nerve to calm down. So it's usually a late morning appointment is better for an asthmatic. But let's get into first some definitions. So pulmonary are lungs. Think of, if you have a patient that comes in and they say that they're under the care of a pulmonologist, you might want to think either COPD or asthma. If you don't see anything on their medical history that would relate to any of that, then we definitely want to ask follow-up questions. What are you seeing the pulmonologist for? What exactly is your diagnosis? When was the last time that you saw them? Um, Apnea, remember, without, pnea is breath, so without breathing. Dyspnea is shortness of breath. Hyperventilation, that is, we want to think hyper, kids, too much energy. Hyperventilation, too much breathing. Orthopnea is they cannot breathe if sitting. They can only breathe sitting up. So if you have them in a supine position, they cannot breathe. Excuse me. Ooh, didn't know that was coming. Oh, so that's the patient, you start to put the chair back and then go, oh my God, I can't lay back. That patient could have orthopnea. Some patients are just have a fear of laying flat. But the orthopnea patient will say, I have to sleep with 3 pillows. This is where we get into nocturnal orthopnea. So nocturnal at night. At night, they cannot lay flat. They have to sleep elevated with pillows. And respiration refers to breathing. So this here is just a little diagram for you, right? We have a common passage here through the mouth of air and food. Um, we have our trachea, which your patients or people you may hear it referred to as a windpipe. We have the esophagus, the throat, trachea. Someone might take a drink and then they start coughing a lot. What might they say? Oh, that went down the wrong pipe. So we think of these as two pipes. Let's see, the diaphragm. What's the diaphragm? That has, it's a muscle of respiration. Does anyone know what some other muscles of respiration are? That would be the muscles that are in between the ribs. If you've ever seen like a baby with croup, those muscles, those intercostal muscles will get involved too, and you might see it really their rib cage when they're breathing. That's really a concern. That's kind of when they would want to go to the hospital. Okay, we are getting into prevention of swallowed objects. Okay, Does everybody know what the rubber dam is or what you would use a rubber dam for? So you might have noticed now we're not working on our typodonts as much. What is it like inside the patient? They are wet and they are slippery, and it is easy to drop something or easy for it to get swallowed. We have two types of mucus, the serous and the and mucus. And you may notice too, as you're pulling your mirror out of a patient's mouth, that this big stringy mucus comes out with them. So we're slippery, right? So if somebody swallows something, where is it most likely going? They're swallowing it, it's most likely going to the stomach. If you hear they aspirated or they inhaled it, then that's going to the lungs. So use of a rubber dam, you may see a rubber dam if doing sealants. Use of oral packing, that's packing gauze in the back of the throat. The high-speed suction, which we are all familiar with that. The intubation forceps, those are those long prong-like forceps that can grab something in the back of the throat. A ligature is if you are going to put a clamp on a tooth, you will see the dentist will tie a piece of floss to it so that if you drop that clamp, you can pull it out by the string. So what happens if someone does swallow something, right? We don't want to all of a sudden panic. Oh my God, did you just swallow that? You're going to make the patient panic, right? And what's the patient going to do when they find out they panic? They're going to want to jump right out of the chair. So we're going to remain calm and we're going to act immediately. Do not allow the patient to sit upright. We want them to be back, right? If they sit upright, what's going to happen is gravity is going to take that object and it's going to take it right down. We want to get the head low so that we can try and see the object. Get them, if you can, in the Trendelenburg position. The force of gravity is going to help return that object to the oral cavity where it can be retrieved. We don't just want to say, if you can't see it, well, oops, it's gone. Search your poop, in a few days, see if anything comes up. We don't want to do that. If something is sharp and it's swallowed, it can cause, it can pierce their GI tube as it's going down. It can cut their esophagus as it's going down. If it's not found, the patient will have to be sent for radiographs. We have to see where it is. Is it in the lung? Is it in the stomach? Did they swallow it? If they swallowed a $1,600 crown and it is in fact swallowed, they may very well try and recover that crown in a few days because $1,600 is expensive. Not necessarily, that they would have to pay for it. It all depends on the situation of exactly what happened. I have also seen it a lot with temporary crowns at home when the patients leave. The temporary crown they don't realize comes off and they're chewing and they swallow it. But if it happens in the office, they are going to be sent for radiographs to see exactly where it is. Okay, so signs and symptoms. So you might first notice that the patient is coughing, but no dyspnea. So they're coughing, they could be gagging, they might feel that pain in the neck, pain in their neck. If you've ever swallowed something really before you're done chewing it well, you can really feel it going down your throat. So that's what they might feel. But once it moves towards the stomach, that pain is gone unless it's really sharp and it's cutting them on the way down. And that's when the pain would continue if it's punctured or if it's retained in the esophagus. So this here is just kind of another diagram of the nasal cavity and then the lower respiratory tract here too with the trachea, the bronchi, the lungs. So now we're getting into the respiratory system. This was a question on the homework too about asthma. Will it, and it has to do with the child with the mixed asthma. Children will very rarely have mixed asthma. I kind of wish the book went into a little more depth with asthma. We'll kind of keep it not too in depth for asthma, but I might go into a little bit more depth in the book. But you got to think, and I'm going to quote Professor Breen here because I kind of like the way that she describes all of this, but we're a human skin suit, right? We're a suit of skin, and inside we are warm and wet. We're like goop, right? So inside we're all goopy and we have our skin suit on top. Air on the outside can be cold and dry. We're warm and wet. Air is cold and dry. Cold and dry into something that likes warm and wet can cause asthmatics to have an asthma attack because the air is dry. So, our bodies are amazing, and we have the intranasal conchi in our nose, if you remember from A&P, and those try to take the air that comes in with our snots that are in our nose and warm it. But that isn't always the case for an asthmatic. So let's talk a little bit about the lungs, right? How many lungs do we have? Two. How many lobes? Does anybody know how many lobes we have? We have five lobes. Another thing I think is amazing about the human body. So we have three lobes on one side and two lobes on another. You have to, if you don't know, but you had to use critical thinking, what side would you think only has two? The side with our heart, because we are making room for the heart. So the body makes room for the heart and it puts three lobes on one side, two lobes on the left side due to the heart. When we look here, we want to think bronchus, right? Think torus, bronchus. That's singular, right? So we have the left primary bronchus, the right primary bronchus. Bronchi would be plural, just like tori. Does anybody know what is that one layer thick wall here where the gas exchange happens? Um, Anyone might remember this, the alveoli. And if we go to the next slide, we'll see this is where the gas exchange happens. These you will hear referred to as like clusters of grapes, not the grapes that we would use to make wine, but the grapes that are going to give us nice gas exchange when we are breathing. So we have our primary bronchus, secondary bronchus, bronchiole, terminal bronchiole, which leads to the alveoli. Okay, so when we have airway obstruction, we first want prompt recognition and treatment. We have decreased levels of oxygen. When that happens and somebody cannot breathe, they're going to start to panic. They might become combative because they are panicking that they cannot breathe. We want to remain calm and we want to make sure that we are having, like I said, prompt recognition and treatment. I like to think too, if we're thinking about airway obstruction, if you have kids, you will always hear, from the pediatrician or the doctor about grapes, right? I think I heard so much about it when my kids were little. I still cut their grapes. Grapes are the perfect size to cause complete airway obstruction. Suck that grape right back, right into their little trachea, can't breathe. Um, so it's always recommended to cut grapes. My son is about to turn 10. I still have a fear of not cutting grapes. And you also want to cut them the long way, not across, because even if you cut them across, there's still that perfect width of the trachea, and you can have kind of a partial airway obstruction where it's opening and closing by that size of the grape. So you always want to cut them the long way because the long way they'll be able to get them down easier. But always cut grapes if you have children or if you're going to have children. So acute lower airway obstruction most often enters into the right stem. If an object becomes impacted in the trachea, then it would be a total airway obstruction. So management of airway obstruction. So if we have a mild airway obstruction, don't intervene. So that's kind of like you are chewing a lot of meat and you feel it start to get stuck, but you can still have that forceful cough. So you want to encourage the person to cough forcefully and try and get that object up. If you're getting into a partial airway obstruction, it's more of a weak, ineffective cough. You'll have that high pitch kind of crowing sound called stridor. If you've ever had a child with croup, you'll know what that stridor kind of sounds like. You want to look for their nail beds to become cyanotic or mucous membranes, and you want to begin to treat that as a complete airway obstruction. So as we move into complete airway obstruction, we all know, I think we've all taken CPR, the universal sign of choking, right? Someone's going to grab their neck. They're going to take either their two hands or one hand and they're grabbing their neck. I will always remember when I was in high school, our teacher told us a story. We were taking CPR in high school and the instructor was out to breakfast, and I think maybe his son was too. His son loved bacon. They're sitting around the table, and all of a sudden they look over and they can see his son, tears only streaming down his face, and he's starting to turn blue. So, complete airway obstruction, you are unable to speak, you're unable to cough, and you're unable to breathe. So, they had no idea that their son was choking until they noticed he was turning cyanotic, and they just see tears streaming down his face. They began the Heimlich and he was fine, thank goodness. But I always remember that as a complete airway obstruction. You might not even know it's happening in a child because, or even an adult, they're unable to speak or cough. They're going to start to panic. They're going to give you that sign for choking as an older child or an adult, someone that knows that sign. Extreme cyanosis, it's going to happen fast, and then it can lead to unconsciousness and cardiac arrest. Okay. So you're going to ask, are you choking? You're going to begin abdominal thrust. Again, we go through all of this in CPR, and you're going to repeat it until it's effective or consciousness is lost. Again, what we learn in CPR. No more blind finger sweeps. If you're alone and you're choking, we get a chair. You try to forcefully hit that chair up against you or bend yourself over the chair. If the person is pregnant, we're going to go above the baby, right almost in between the breastbone there and try that. Um, and if it's a baby that's choking as well, an infant, right, we're going to do the back blows and we're going to flip them over. It's like the baby pancake. You're flipping, you're flipping, you're flipping. But that's what we're going to do for that. Wow. Okay, I wasn't aware of all those sounds. Um, But if they become unconscious, we're going to activate EMS, position supine. We're going to begin chest compressions. And before ventilation, we're always going to look to see if we can see that object, right? Remember, no blind finger sweeps. We're not going to go too much into invasive procedures because this is something that we will never do. Tracheotomies used to be the former method of choice. Now it's really used for long-term airway maintenance. Remember, I'm sure we're all heard about people going on to ventilators with COVID. That's really when you would do a tracheotomy. It's not really done as much anymore. Again, we are not trained to do this. The cricothyrotomy, this is now the method of choice of choking. This is when an incision is made in the cricothyroid membrane, and it wants to be made below the object to allow for airway, to allow for air to get into the body. Okay, hyperventilation. We talked a lot about this the other day. Who's the most common that we're going to see hyperventilating? Mostly, typically young women. Could it be an older man? Absolutely. But typically we see it in younger women. When will you recognize the patient that's hyperventilating? Usually, when we're doing vitals, if their breathing is considered rapid, they might start to begin hyperventilating. So the biggest thing is that we want to break that chain of hyperventilating, which we talked about before, coaching them how to breathe. The biggest cause, anxiety, right? That's the biggest cause that we will see is acute anxiety. Pain may also bring it on. Drugs, illicit drugs such as cocaine might cause hyperventilating. CNS disorders, they're very rare and obscure, and we're really not going to go much into that. So signs and symptoms of hyperventilating. They're nervous. They're an increased rate and depth of breathing. They're feeling, tightness or suffocation. They might also end up with some ischemia that causes their extremities to get a little tingly and numb. The biggest thing, we are going to remain calm, right? We're going to be calm so that we can coach that patient through breathing, cup their hands around their face if they need to, breathe in and breathe out, right? So the pathophysiology, the anxiety increases that respiration. And then as the increased respiration, if we do not have COPD, they're blowing off too much oxygen. So as they're blowing off too much, their level of CO2 in the blood drops, and the level of CO2, as long as we don't have COPD, is kind of what tells us when to breathe. Like I said before, we don't say, I think I'm going to breathe now, and I think I'm going to blow out. I think I'm going to breathe. I think I'm going to blow out. No, our body tells us when to breathe. It keeps track of that for us. So when this cycle occurs, we must intervene and break the cycle with them. Again, deep breath in, help them, coach them through, and get their breathing back under control. If we're relaxed, they're more apt to be relaxed. So again, management of hyperventilation. What is a unique feature of hyperventilation? You may see on your boards, you may see it on a test. So we don't give oxygen. There, we want to not provide oxygen because we want that reflex to breathe more to come back on their own. Again, if they're hyperventilating and they have to think about breathing, that might cause them to be more nervous as well. So we want to try and really just get them to be calm. In cases of severe anxiety, or if the patient is someone that chronically hyperventilates, anti-anxiety meds can be given, such as Ativan. You might hear an anxiety med given, if you're afraid to fly or you're nervous in any types of situations, those anti-anxiety medications really are effective. Okay, now we'll get a little bit more into asthma. Like I said, it is not well talked about too much in the book. It kind of just gives the brief overview. But what is asthma? So there's different types, and we'll kind of go into those different types, but it's a chronic respiratory disorder that produces periodic reversible airway obstruction. It's caused by bronchospasms and hypersecretion of the bronchial mucus glands and the bronchial wall edema. The classic signs are dyspnea, wheezing, and coughing. So extrinsic asthma, also known as allergic asthma, let's see. This is also, you might see it referred to as childhood atopic asthma. You're usually aware of your triggers and what bring on attacks. We want to be aware of dyes and preservatives used in dentistry. For example, dyes that could be used in fluoride or disclosing that could bring on or trigger an event. Other common triggers can be dust or pollen, and that bronchospasm can usually develop within minutes after the exposure of that allergen. The other thing to remember too is this is, again, common in children, but 50% of children outgrow this. So I know for myself, I had kind of severe asthma as a kid. It does favor more in boys than girls, but I had pretty severe asthma as a kid. By the time I was about a teenager, it was gone. And I haven't had anything since. Same with my son, had asthma as a baby, and it's already really, he's grown out of it by almost 10 years old. The other thing to keep in mind too is, so they're usually symptom free between attacks. So it's until that trigger is brought into the picture. Otherwise, they're usually symptom free, and it responds well to medication. So intrinsic asthma, this also can be called infectious asthma, usually develops in adults over the age of 35, and this is usually more common in middle-aged women. This is just a side note of something that I learned, but they think it could be testosterone flush in women in menopause that could bring this on. And men don't have that testosterone flush at a later age. They have it much younger. And I think that this kind of can trigger, again, it's just kind of something I learned about, and you probably won't see it on a test, but I thought it was interesting. Um, but attacks are brought on by respiratory infection, irritating inhalants, cold air, exercise, and stress. So downstairs in the clinic, you might see exercise-induced asthma as an ASA3 because they're really unaware what can bring on or what their triggers are, not just exercise. Um, but if they know what their triggers are, then it's more likely an ASA2. And this type of asthma is no history or allergy or anything like that. So then we get into a mixed type. So a mixed type, now say when I was younger, I had extrinsic asthma, I got better. Say within the next 10 years, I developed asthma again. That would be a mixed type of asthma. So I had it when I was a kid. Now I'm an adult and I get it again. So that's mixed type. And it's most difficult to treat in patients. It's a combination of extrinsic and intrinsic. And it's usually brought on by an infection. Um, and it also could be kind of an autoimmune disorder as well. Status asthmatics. This is also kind of an older term, but it's probably still what you will see on the boards. This does not respond to the usual drug choices for the course of action, and it can be life-threatening. So this means, we give epi and then we give it albuterol, and it's not helping with the asthma attack. It's very rare, um, but again, epinephrine is the first drug of choice, and then we treat with the bronchodilator. So dental precautions. We want to avoid the allergens, right? Are we exposing them to dyes that could be a trigger for them? When was the last time they had an asthma attack? Have they ever been hospitalized? Um, Dialogue questions. Those are really the dialogue questions that you want to have. We want to avoid aspirin, penicillin, codeine, erythromycin. Now, local anesthetics, right? So local anesthetics which contain sulfites. Do all local anesthetics contain sulfites? No. So sulfites are preservatives to help preserve the epinephrine that is found within local anesthesia. If you find a local anesthesia that does not have epi, so you might see that it's listed as plain, that does not have epinephrine in it, it may not get the patient as numb as you want, but that would not have any sulfites in it. Some other dialogue questions you want to have with an asthmatic patient. What age did they develop asthma? What type of asthma do you have? How often do you have attacks? Describe a typical attack and how do you manage them? Have you ever been required emergency care or hospitalized? Have you ever had an attack in a dental setting? Do you take any medications? If so, how much? Um, and how often? So what we want to do too is if they come in, they have asthma and they don't have their inhaler with them, what are you going to do? You're going to go over to the med cart, you're going to get the albuterol, you're going to sign it out, put it in a little bag and bring it to your unit. Is the patient going to sit up and say, "Oh, I feel like I could be needing some albuterol right now, and we're going to take it and give it to them"? We're not. That's left for the doctor or your faculty to decide, but we are going to keep it chairside just in case. However, the patients Inhaler is always better. So if they bring it with them, have it out at your unit, encourage them to bring it with them. So ASA classifications. ASA 2, infrequent attacks. It's easily managed. They've never been in the hospital. ASA 3 is frequent attacks, exercise-induced asthma. So that's with exacerbation. So even just anything that could bring on an attack with physical exercise. Your anxious patient, prior history of emergency care or hospitalization. ASA 4, we're probably not going to see. That's chronic signs and symptoms of asthma at rest. That means they are getting asthma attacks without doing anything. We're going to do a medical consult. We're going to delay treatment. We're really not going to see them. So, signs and symptoms of attacks. So, a mild attack, wheezing, coughing, feeling of thickness in the chest, um, dyspnea, increased anxiety, increased heart rate, and blood pressure, shortness of breath as well. Severe attack. And these are all kind of continuing on from each other. Severe attack is intense dyspnea, orthopnea, sweating, flushing of the face, cyanosis of the mucous membranes in the nail bed, fatigue, and mental confusion. You might see something called air sniffing or air hunger. They're really trying to get that breath in. Their nose kind of comes up a little bit. They need that air. That's very characteristic of a severe attack. If it keeps going, then you can get into the status asthmatics, which is an acute episode and it continues despite going into all that drug therapy. So when do we want to call EMS? Do we want to wait until they're a status asthmaticus or no? I would say severe attack, it's not going away. They're starting um, to get that cyanosis, mental confusion. We're calling EMS. Because once it keeps going to, then there'll be required hospitalization. Okay, so let's go into lungs before of an asthma attack. So see this cross section here? See how nice and open that is? That's as the smooth muscle constricts and gets smaller, and then everything gets thicker. So there's bronchoconstriction. So this here is going to start to get thicker. And then as it's thickening, we get edema. So mucus is good, but excess mucus that produces in asthma starts to block the air in the lungs during asthma attacks. That's when you get that wheezing sound, right? The whistling. That's when the tubes start to narrow and you start getting those um, that sound coming. What happens too is you start getting shortness of breath. So as the air is, your breath, the CO2 is rising, we start getting air trapped within the alveoli, and that air can't get out. So the pathophysiology, so there's chemicals released that cause bronchospasms. So if we think back to A and P, we have to kind of think back quite a bit. um, the IgE cells attaches to those mast cells, which are your chemical mediators that are released from the mast cells, and that's what starts to cause bronchospasm, edema, and hypersecretion of mucus. So what does that albuterol do when you take that albuterol? That's a bronchodilator. So it's going to help create good air exchange. So as those bronchospasms and edema start to happen, the albuterol comes in and it's going to create that good air exchange. It's going to dilate those bronchioles because we're going to get bronchial wall edema due to inflammation, that hypersecretion of the mucus glands, so thick plugs of mucus in there, and that's when we want to take that bronchodilator. So here's the pathophysiology during an asthma attack, right? So we start to get that spasm, right? So it's not that round, nice circle anymore, it's spasming. As it spasms, we get edema, the swelling, then comes the mucus. So now we had that nice air exchange, that nice open airway. Then we get the spasms, we get the swelling, add in the mucus. Look at how small that is there. So that's really hard to get a good breath in. So that's when we want to take in that inhaler and help to open up those tubes. So that's kind of what we just talked about. Decreases the size of the lumen, partial airway obstruction, increased airway resistance, decreased levels of O2, changes in the blood chemistry and pH can also lead to anxiety and hyperventilation. So management of acute attack. We want to get the patient upright, get the weight off their chest. So stop treatment, position the paper up, administer a bronchodilator by inhalation. We're going to give them oxygen, right? If it's not getting better, we're going to give an intramuscular injection of epinephrine. We're going to summon medical assistance if this is having no effect. So especially if this is not helping the patient, we're calling EMS and we're getting this patient the help that they need. If the patient is able to recover, we're going to make sure that they fully recover before dismissal because they are definitely more apt to have another asthma attack. So we're going to stop here and there will be a second video and we'll start going into COPD.